Typhoid fever is a bacterial infection caused by Salmonella Typhi. It predominantly spreads through contaminated food and water, common in areas with poor sanitation. The disease can have serious health consequences if left untreated, making awareness crucial for prevention and management. The symptoms of typhoid fever often appear 1 to 3 weeks after exposure. Initial signs include a high fever, fatigue, headache, and abdominal pain. As the illness progresses, patients may experience severe diarrhea or constipation, rose-colored spots on the torso, and an enlarged spleen or liver. The symptoms can vary in intensity and duration, often mimicking other diseases, which complicates diagnosis. In the first week, the body temperature rises slowly and fever fluctuations are seen with relative bradycardia, Faggot sign, malaise, headache, and cough. A bloody nose, epistaxis, is seen in a quarter of cases, and abdominal pain is also possible. In the second week, the person is often too tired to get up, with high fever around 40 degc, 104 degree, and bradycardia, classically with a necrotic pulse wave. Delirium can occur, where the patient is often calm but sometimes becomes agitated. In the third week of typhoid fever, a number of complications can occur. The fever is still very high and oscillates very little over 24 hours. Dehydration ensues along with malnutrition, and the patient is delirious. Low platelet count thrombocytopenia is sometimes seen. Respiratory diseases such as pneumonia and acute bronchitis. Typhoid fever is caused by the ingestion of food or water contaminated with Salmonella Typhi. The bacteria thrive in the intestines and bloodstream of infected individuals. Poor hygiene practices, including inadequate hand washing and improper food handling, facilitate the spread of the bacteria. In some cases, individuals might carry the bacteria without showing symptoms, acting as carriers and inadvertently spreading the infection. No animal carriers of typhoid are known. Humans are the only known carriers of the bacterium. Enterica subsp. Enterica serovar typhi is spread by the fecal oral route from people who are infected and from asymptomatic carriers of the bacterium. Diagnosing typhoid fever requires a combination of clinical evaluation and laboratory tests. Blood, stool, or urine cultures are commonly used to detect the presence of Salmonella Typhi. Additionally, serological tests like the Vidal test can help identify antibodies against the bacteria. Early and accurate diagnosis is critical to ensure prompt and effective treatment, preventing complications and further transmission. Preventing typhoid fever hinges on maintaining high standards of hygiene and sanitation, ensuring access to clean drinking water, proper sewage disposal, and rigorous food safety practices are fundamental measures. Vaccination is also available and recommended for individuals traveling to regions where typhoid fever is prevalent. Educating communities about hand hygiene and safe food practices can significantly reduce the incidence of the disease. Treating typhoid fever typically involves a course of antibiotics. Commonly prescribed antibiotics include ciprofloxacin and azithromycin, which target the Salmonella Typhi bacteria. Supportive care, such as adequate hydration and rest, is also crucial during recovery. In severe cases, hospitalization may be required to manage complications and provide intravenous antibiotics. Prompt treatment is essential to mitigate the risk of severe health outcomes. Typhoid fever remains a significant public health challenge in many developing countries. It disproportionately affects children and those with compromised immune systems. The World Health Organization estimates millions of cases globally each year, with a notable number of fatalities. Efforts to combat typhoid fever focus on improving sanitation, advancing diagnostic methods, and increasing vaccination coverage. Before the antibiotic era, the case fatality rate of typhoid fever was 10%, 20%. Today, with prompt treatment, it is less than 1%, but 3% or 5% of people who are infected develop a chronic infection in the gallbladder.